Good afternoon, everyone. We welcome you all to this month's clinical pathological discussion. Today we have a interesting case from Pulmonary department. For that, to discuss from the clinical side, it's a great pleasure to invite Professor Ashesh Dhungana. Sir has done his medicine from PG Chandigarh and DM from Pulmonary Medicine from the same institute. Currently, he is the Dean of National Academy of Medical Science, Bir Hospital, Kathmandu, Nepal, and he is a Professor of Pulmonary Medicine and Chief Consultant, Chest Physician from Government of Nepal. He has a vast research and clinical experience of 15 years. His areas of interest include interventional pulmonology, sarcoidosis, and interstitial lung disease. He has multiple papers in national and international index journals to his credit. And he has received the prestigious President's Medal for his work, for his research and clinical work. So it's a great pleasure to invite you, sir, to our discussion. Over to you, sir.
Thank you, Dr. Bala. It's indeed a great pleasure to be back here and the Department of Pulmonary Medicine for inviting me for this clinical discussion in clinical pathology. So I've been given a case. Let's go into the case history. She is a 30-year-old lady, a resident of Delhi and an administrative officer by occupation. She presented with chief complaints of dry cough for 3 months, which was insidious in onset. The cough was static for the first 2 months, but has mildly progressed over the last month. It was predominantly present during the daytime, and this cough had no any exacerbating or relieving factors, and there was no associated hemoptysis. She did not complain of any other respiratory symptoms such as shortness of breath, chest dysphagia. She has no history suggestive of atopy, rhinitis, or any seasonal variation of her cough. There are no constitutional symptoms. There are no history symptoms suggestive of an underlying connective tissue disorder. She did not complain of any pain abdomen or history suggestive of gastroesophageal reflux, and there were no neurological symptoms in the form of headache, focal neurological deficits, or seizures. She was a never smoker and a teetotaler. She did not have any prior known comorbidities. She was a mixed diet consumer. She had a normal bladder and bowel habit. She was married with no children, and she had no past history of abortion. On examination, her general physical examination was normal. There were no palpable peripheral lymphadenopathy. The respiratory system examination, abdomen system examination, and other examinations were all within normal limits. These are the investigations that I have been provided with. Her hemoglobin was 12.7 gram %. Platelet count, total leukocyte count, the differential counts were normal. Peripheral blood smear showed normocytic, normochronic RBCs. Her ESR was slightly elevated, which was 35 millimeter in the first hour. Her coagulation parameters were normal. Renal function tests were normal. Calcium levels were normal, and the liver function tests were also normal. She went. Her hepatitis B, hepatitis C, and HIV tests were negative. Rheumatoid factor, anti-CCP, anti-nuclear antibody, dsDNA antibody, and ENA panel were all negative. Her ANCA test, which was done by TR3 ELISA, was negative. She had a normal beta HCG level and a protein level. Her spot urine albumin creatinine ratio was also normal, that is microalbuminuria, and her urine routine examination was normal. Investigation that I can think of, which I would have liked to have, was serum LDH, and I'll slightly discuss on the role of serum LDH and whether it would have helped us in narrowing any diagnosis. This is the chest X-ray that has been provided to me. This X-ray is quite remarkable that it has bilateral, variable-sized, round, multiple lung nodules and masses. So these are the pulmonary masses. You can see these are all more than 3 centimeters. They have a very smooth margins. There is no lower predilection. That is, you can see some nodules even in the upper lobes, in the lower lobes, and the intervening lung parenchyma is normal. The diaphragm, the CP angle, the cardiac shadow, the soft tissue, and bony case appears to be normal in this X-ray. CT representative of the upper, middle, and lower lobe cuts have been provided. I was only given this non-contrast CT images which confirm the presence of these multiple lung masses or nodules with regular margin. Since there was the contract was not specified, so I do not know whether these masses were heterogeneous or homogeneous and about the contraction enhancement. What I can say from the images is that there is no significant mediastinal lymphadenopathy. The intervening lung parenchyma is unremarkable, that is normal, and there is no significant, there is no any infusion. Similarly, PET scan has also been provided. On PET scan, these masses were FDG avid. They have the SUV max value was not provided, but these are lighting up, so most likely the SUV max value was more than 2.5. The breast tissue that is visualized in these cuts appear to be normal, and I have not been given other organ cuts, but I assume that there was no other organ involvement with abnormal uptake. That is, there was a normal neck abdomen pelvis scan. Bronchoscopy was done in the pulmonary medicine department here. Flexible bronchoscopy was normal. A radial probe endobronchial ultrasound was done. We showed an eccentric ultrasonography abnormal area. So likely probe was present beside the lesion in the left lower lobe. And from that lobe, a bronchoalveolar lavage was done and a biopsy was done. The bronchoalveolar lavage samples were negative for gram-scale bacterial culture, fungal culture, AFD gene expert, and bowel cytology did not reveal any organism or reticular cells. The transbronchial lung biopsy done from the left lower lobe lesion did not clarify the diagnosis. So to summarize, this was a 30-year-old lady with dry cough, only symptom of dry cough for 3 months. She had bilateral FDG, avid lung nodules and masses. What I am trying to fit here is a slightly raised ESR, and as I already said that LDH is not available. So if you look into ESR is a non-specific marker of inflammation. It rises in various conditions including infections, tumors, and autoimmune disease. A mild to moderate elevation of ESR is rarely helpful in making a diagnosis, whereas an elevation of more than 100 millimeters points towards diagnosis of either tuberculosis, multiple myeloma, polymyalgia rheumatica, giant cell arteritis, or hypersensitive vasculitis. A form of lymphoma, which is lymphoplasmacytic lymphoma, commonly called the Waldenstone macroglobulin, may also has very high ESR. Would serum LDH test help? LDH is an enzyme released into the bloodstream in tissue damage of heart, liver, kidneys, muscles, and blood cells. Very high levels may be present in hematological malignancies such as leukemia and lymphoma, with hemolysis, and also tumorolysis in vasculitis and in tumorolysis syndrome. The major disadvantage of serum LDH is too non-specific towards a diagnosis, but a very high LDH level may indicate an aggressive tumor or poor prognosis. What we also need to understand before we delve into, because most of the discussion will be based on radiology, because that is the thing which is strongly positive, which is very glaring in this patient. So we need to be able to differentiate between a lung nodule and a lung mass. A lung nodule is a circumscribed, mostly solid lesion that measures less than 3 centimeters in diameter, whereas lung masses are lesions which are more than 3 centimeters. We also need to differentiate these lung nodules and lung mass with consolidation, which are a circumscribed lesion that has aerated alveoli and air bronchogram, and a cavity which is air-filled space in a low attenuation area within a nodule mass or consolidation. Now something on anticipate avidity or the standard uptake value SUV. So if we use a PET scan to differentiate between malignant and non-malignant lesion. Benign or lesions with low metabolic activity show SUV max of less than 2.5. Malignant tumors or lesions of high metabolic activity show SUV max of more than 5. Anything between 2.5 to 5 protects towards the suspicious activity and needs further evaluation. So for differentiating malignant from non-malignant condition, if SUV max is more than 2.5, the sensitivity is very high, positive predictive value is high, whereas specificity is lower. But there are always false negatives, malignancy with low metabolic activities such as carcinoid or bronchoalveolar carcinoma to low FDG avidity, whereas inflammatory lesions such as infections, fibrosis, and vasculitis have high FDG avidity. So these are the causes of lung mass. We can broadly divide them into 4 categories. The neoplastic is the most common causes of lung mass. Maybe different types of tumors, then inflammatory lesions, immune lesions, and infiltrative lesions. Infections such as multiple lung abscesses, septic emboli, fungal infections, and related cysts may sometimes present mimic a mass on radiography, but these have fluid densities, these are features of other lung involvement and systemic symptoms, and vascular and anatomic lesions and lung mass mimics such as round atelectasis are readily differentiable radiologically. So I'm not considering these diagnoses in my final differential diagnosis. So what I will be delving upon are neoplastic causes, the most common of which are bronchogenic carcinoma, metastasis, bilateral metastasis to the lung, and lymphoma of the lung. The lesser common ones are the carcinoid tumors and hematomas, and rare forms such as inflammatory myocardioplastic tumor or a perivascular epithelioid tumor, picoma, benign metastatizing leiomyoma, and sclerosing pneumocytoma. Amongst the inflammatory lesions, vasculitis and organizing pneumonia are common occurrence. Even rheumatoid pulmonary nodules are common. The radiological features are quite distinctive, which I will be discussing in subsequent slides. And rarely a sarcoidosis or pulmonary embolism may present in the lung mass. So let's go into some common lung tumors. Bronchogenic carcinoma rarely presents with multiple bilateral lung mass without involvement of any other structure, such as intervening lung or having an endobronchial lesion with a consolidation or atelectasis or a mediastinal lymphadenopathy. So only amongst bronchogenic carcinoma, the diagnosis which might be of contention is synchronous primary lung cancer, that is 2 or more primary lung cancer at the same time, but these are rare. These mostly occur in middle-aged to elderly smokers. These are mostly either adenocarcinoma or squamous cell carcinoma, but they present with hemoptysis and constitution symptoms such as loss of weight. It was not present in our patient. These present as nodules or mass with stipulated margins. So the margins in this case was very regular. So I'm not considering this. Another variant which is more common in young non-smoker recent females is multifocal lung adenocarcinoma. These have a spectrum such as atypical adenomatous, hyperplasia, adenocarcinoma, and situ or multifocal invasive adenocarcinoma. But the characteristic feature of lung adenocarcinomas in females is that these are mostly ground-glass to partly solid nodules or nodules or masses were solid. So I'm not considering this, and there is also consolidation or hallucination or an airborne occurrence. After primary bronchogenic carcinoma, the most common bilateral lung mass is caused by metastasis to the lung. Lung is a very common site for metastasis. In males, exclusively testicular and prostate cancer can metastasize to lung. Mostly in females, breast and ovarian cancer, and melanoma, renal cell cancer, colon cancer, or osteosarcoma may metastasize in both genders. So could this be an occult primary with a PET negative? So PET negative have been found in a few cases of occult primary lesions, but these tumors are usually less than 4 to 5 millimeters and have a very low metabolic activity. But one dictum that should always take place is that FDG uptake intensity of the primary and secondary are almost always same. So it is very unlikely that these lesions which lighted up in the lungs in the PET scan did not go to the primary side. So I am not considering this diagnosis as well. Lymphoma, which is less common than metastasis and primary lung cancer, but relatively, I think, present in lungs, occurs in lung in two forms. That is metastasis from the extrathoracic lymphoma, which is pulmonary involvement in extrathoracic or diffuse lymphoma, commonly occurs in lymphoma in around 12% and NHL 4%. Another variant is primary pulmonary lymphoma, which is a monoclonal proliferation in the lungs without detectable extrathoracic lymphoma for at least 3 months after the initial diagnosis. So primary pulmonary lymphoma is not very uncommon. It represents 3 to 4% of extranodal NHL and 0.5 to 1% of primary pulmonary malignancies. Lung involvement of primary pulmonary lymphoma is frequently bilateral and manifests as nodules and mass, and these green pointers are present in our patient. So if we look into the radiological manifestations of lymphoma, masses are not the common manifestations, but they are present in significant number of patients. It may present as a solitary or multiple nodules, masses or mass-like consolidation. The size of the lesion may range between 5 millimeters to 8 centimeters, and some masses may cavitation. So even amongst the primary the lymphomas of the lung, secondary pulmonary lymphomas or diffuse large B-cell lymphomas are very aggressive and have ill-defined border and show features of cavitations, whereas PPL, primary pulmonary lymphoma, uh, presents with nodular mass and has less cavitation and a smooth border, and 80% of them may present without lymphadenopathy. A patient did not have consolidation, ground glass opacity, perilymphatic distribution or pleural involvement, so which is again against diagnosis of lymphoma. So primary pulmonary lymphoma may occur in three forms. The first form is extranodal marginal zone lymphoma, mucus-associated lymphoid tissue, which is commonly called the mild lymphoma. It occurs in 5th to 6th decade of life. In immunosuppressed patients, it may present at a younger age. It has a slight male predilection. There are few or no symptoms. The only symptoms may be cough, which is present in our patient. These may present as non-cavitating nodules or masses, but there have been many reports of marked lymphoma which have cavitated and have ground glass appearance. Diffuse pulmonary, primary pulmonary DLBCL is also one of the common lymphomas. It presents in 5th to 8th decade, presence of cough and hemoptysis, and there is significant presence of systemic symptoms, that is B symptoms, loss of weight, fever, night sweats, and this may be either cavitating or non-cavitating. Lymphatic granulomatosis are commonly now termed angiocentric immunoproliferative lesions are slightly less common than the upper two forms. These occur in young and middle-aged adults, but these usually occur in immunosuppressed HIV positive or transplant recipients with the disease is EBV driven. There are other organ involvement. So amongst primary pulmonary lymphoma, I am considering external marginal zone lymphoma. There are a few features which are consistent with primary pulmonary diffuse B-cell lymphoma, apart from the systemic B symptoms that these patients have, and I'm not considering lymphoma. Now, a few uncommon lung tumors. Pulmonary hematoma is by far the commonest benign tumor of lung in adults. It has multiple components, that is the same tumor as cartilage, epithelium, fat, and muscles. It is often detected incidentally and grows slowly. It presents in 5th to 6th decade and has a male predilection of around 4:1. It is usually solitary, but peripheral masses of less than 4 centimeters have been reported. It has a well-defined edges. What is very characteristic of pulmonary hematoma is the popcorn calcification inside the lesion, which is pathognomonic, and most of the times if these are found, biopsy may not be required, but there may be variants of hematoma which do not have calcification, and fat density may be too small to be visible on CT, and few hematomas have indeterminate FDG uptake. This was one of the unusual case report that I found of a multiple pulmonary leiomyomatosis. So the major component here was leiomyoma. It is more common in females. It is associated with uterine leiomyoma. There have been, I think, arguments whether it is a form of benign metastatizing leiomyoma, which I will be discussing in my subsequent slide, which is one of the differential diagnoses as well. This presents with multiple solid nodules and masses, and there is absence of classification. So I am considering this diagnosis. Pulmonary carcinoid tumors, these are neuroendocrine tumors, consist of 1 to 2% of all primary lung cancers. So these are not very uncommon. These have female predilections. They are divided into two types: the low-grade typical carcinoid, which are the majority, and high-grade atypical site carcinoid, which constitute the minority numbers. Carcinoids are classically located as single nodules close to the hymen or endobronchial lesions. They may rarely present as peripheral lesions, and exceptionally, there is less than 1% have been reported multifocal. Mediastinal lymphadenopathy is common in both low-grade and high-grade carcinoids, and calcification is seen in around a third of cases. So I'm not considering pulmonary carcinoid tumors because multifocal involvement is rare, and central lesions are more common, and there is no mediastinal lymphadenopathy. One variant of neuroendocrine tumor is diffuse idiopathic neuroendocrine cell hyperplasia. commonly called the dyspnea. These are multifocal and peripheral, but they do not present with lung mass. They present with a lot of nodules. As we can see in the picture, they present with symptoms of asthma with cough and wheezing, and there are multiple micronodules, so I'm not considering these as this. The other common uh, rare tumor of lung is inflammatory myofibroblastic tumor. These are low-grade mesenchymal malignancy, also common inflammatory pseudotumors. They occur at all ages, but most in less than 40 years. Two forms have been reported, invasive and non-invasive, and invasive forms may reach large sizes. But 80% of IMTs are solitary. Multiple masses are rare. They are usually added on PET scan, and calcification is common. So that is why I'm not considering this. Other rare tumor, perivascular epithelial cell tumor or the picomas are extremely rare. So only around 200 to 300 cases have been reported in literature from the lung. They are more common in extra pulmonary sites such as genitourinary system, retroperitoneal or GI tract. There are two categories: the angiomyolipomas and lymphangioleomyomas have different presentations in the lung. They present with cystic lung disease, but picomas and NOS may present with the lung mass, and they are mostly benign but rarely malignant. And if malignant picoma of organ other than lung occurs, then the most common site is lung. There have been case reports of primary pulmonary picoma reported. This is one of the case reports I found, which was FTG avid. It has a strong female preponderance, but they and have smooth margins, no evidence of cavitation or calcifications, and may rarely present with thrombocytosis. Because it is usually solitary, so I'm also not considering this. Benign metastatic leiomyoma is again extremely rare. Only hundreds of cases have been reported in literature. This is thought to be a hematogenous metastasis from morphologically benign uterine tumors such as leiomyoma. It presents 3 months to 20 years after post-hysterectomy or myomectomy. Our patient did not have any history of hysterectomy or myomectomy, but a few tumors may be detected before hysterectomy. And we should also note that CT scans are less sensitive than MRI for small intramural leiomyoma. So small intramural leiomyoma may have been present in this patient. So and I found this case report which was reported in Lung India around a decade back with solitary pulmonary nodules of bilateral masses, well circumscribed, no lower preponderance, no cavitation, calcification of intestinal lymphadenopathy. These are non-enhancing. So this picture looks more like what our case looks like. So I am considering this also as a rare possibility. Primary sclerosing pneumocytoma occurs in most commonly in East Asian or Japanese patients, usually in females. There are 3 variants, one of which is solid, but there are other radiological signs such as pseudocapsule that is surrounding the tumor, or an overlying vessel, or an air gap around the vessel, or halo sign which is not present in our patient. So I am not considering this. Short on inflammatory or immune causes, pulmonary vasculitis, I am not considering because these are heterogeneous group disorders characterized by considered inflammation of blood vessels. It has multi-system involvement. There have been reports of lung-limited vasculitis, but most of them are anti-associated, 75 to 95%. The granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, or microscopic polyangiitis are 3 forms that have been reported. They are characterized by elevated ESR and CRP, but they frequently have renal involvement in the form of proteinuria or active urinary sediment. And the lung lesions may present as a mass, but they have characteristic cavitation, and they also have a halo sign, that is a ground glass which is surrounding the mass, or a reverse halo sign which is the atoll sign, which is not present in our patient. Necrotizing sarcoid granuloma, again rare, less than 150 cases reported. The pathogenesis is unknown. Whether it is a variant of sarcoidosis with inflammation extending into the wall of blood vessels, or a pulmonary form of pulmonary vasculitis with sarcoidal reaction is not known. They present with symptoms of cough, dyspnea, and what is characteristic is that these are nodules and consolidation. So as you can see in picture, there are ground glass opacities around this lung mass. So and mediastinal lymphadenopathy is also less common than sarcoidosis, but present in most of the cases. So I am not considering this. Another infiltrative disorder which I am considering is nodular pulmonary amyloidosis. These are abnormal deposition of amyloid protein in the lung. The nodular parenchymal form are characterized by deposition of amyloid light chain or mixture of amyloid light chain and heavy chain proteins. These present slightly late in the sixth decade. They are asymptomatic and they are uh, reported to be associated with other malignancies such as mild lymphoma or adenocarcinoma or autoimmune disease such as Sjogren's disease or lymphocytic interstitial pneumonia. This was one of the case reports that I found, which showed that these had sharp, smooth, and lobulated contours. Their calcification has been reported in literature to be about 50%. These are variable size. The size can reach up to 15 centimeters, and cavitations are rare. And there is usually some of the amyloidosis may be FDG habit, but there is always differential uptake. That is, it is not uniform uptake of FDG. So, because it presents with bilateral masses, I am considering this as a rare possibility. So, let's look into the four differential diagnosis in a patient. So, for primary pulmonary lymphoma, it may present in patients with female or reproductive age. It may present with minimal symptoms, especially the bad lymphoma present with very minimal symptoms. There are presence of bilateral masses which have been reported in patients with primary pulmonary lymphoma, and these lymphomas are FDG. Regarding hematoma, it may present, it has more predilection towards male, but have been reported in females. They have minimal symptoms, most of them are asymptomatic. It rarely presents with bilateral lung mass, and they are not usually FDG. Benign metastatic leiomyoma, they are common in females. They have minimal symptoms. They have bilateral lung nodules and masses, and they are FDG. Nodular pulmonary amyloidosis, females have been reported to be presenting with this. Their symptoms are minimal because these are only infiltrative process and it has to be extensive to produce symptoms. They sometimes present with bilateral mass, but FDG uptake is either absent or differential. So my final diagnosis I would like to consider is neoplastic primary pulmonary lymphoma, extranodal marginal zone lymphoma of mucus-associated lymphoid tissue, Mark lymphoma. I would also like to keep a rare possibility of primary pulmonary DLBCL. Amongst rare lung tumors, I would like to consider hematoma as it is more common than other uh, benign lung tumors. And amongst those, I'd like to consider multiple pulmonary leiomyoma, hematoma, or benign metastatizing leiomyoma, and a very rare possibility of nodular pulmonary amyloidosis, which may or may not be associated with mortality. There is always a dictum that when we hear of hoop page, always think of horses because they are more common and not about zebras. So if somebody pushes me to give me a single diagnosis, I would go with primary pulmonary lymphoma, extranodal marginal zone lymphoma of lymphoid tissue, that is MARD lymphoma. Thank you.
Yeah. Thank you, sir, for the wonderful discussion. Before going to the pathology part, I'd like to invite any comment from the audience to sir or for a general discussion. Any other differentials you'd like to consider apart from the ones which were discussed? Yes. Dr. Siddharth?
No, but we can discuss the other differential which would have been like kind of more should have been considered in the final would have been the identical female patient, multiple masses, not really effective. History is not going that way. We had considered differential from West first because giving the appearance of this hole coming from somewhere else side. Or there is a primary in the nerve itself, and there is one of them is education, the rest is all met. So that there are commoner ones which one will think of and will start their investigation accordingly.
I think it's a fantastic case for CPC because no matter who you ask, they'll give their own possibilities depending on the kind of cases they see. Fantastic case that way, very difficult to do a lot of differentials. But I want to say from my perspective, that to talk about limited feature or localized disease, you see the historic descriptions perfectly these patients. Just isolated lung masses, unless the biopsy, they will not be able to make a diagnosis. Essentially, because limited or localized DPA is prone to be ANCA negative. And if it is not involving the classical side, it's very difficult to make a diagnosis short of a histopath. So, can like this way as well, especially if you're saying it's a well-preserved female, no significant constitutional symptoms, elevated TSR. Probably that's something that very difficult to completely rule out in the short of a But again, a lot of things.
So I think that's a good point. I just wanted to ask you that what would be the likelihood of ANCA negativity if we do have a GPA with this kind of harms?
So localized GP anchor negativity is around 50%. If you see these curves. But limited TP also comes in various forms. It may be limited to the upper respiratory tract, it may be limited to the orbit, it may be limited to the lungs. The anchor negativity is 50%, very high. So anchor negativity does not
rely much on
does not rule out. You have to sample this.
Thank you. Any comment from the clinician, sir? How we worked out this case without revealing the diagnosis?
I was following this patient up. What Dr. Priyanka brought out was when you saw this kind of asymptomatic with, I think malignancy and metastasis was something which was in my thought process. And she was carrying some report. I think she carried a report of a biopsy which was inconclusive. And things were also going in the line of what Siddharth mentioned in terms of GPA. But I think let's hear from the pathology. And then we can actually discuss that, what we thought and how this case. Any more comments on a question on differential are most welcome.
I'm just trying to ask similar to the
Nuclear medicine,
Sir, can I guess?
what would you think?
Comes from nuclear medicine.
But CT we have only the test images there, but I assume that this patient have no other disease. That's why CT images of the lung has been given. So from the images it seems that this is a metastatic. But if there is no primary investments, then the other differential will come into the role like lymphoma. So I think
So pet-wise, one cannot differentiate primary from metastatic in the lung, is it? Or can be?
largely primary and metastatic both show the similar uptake. They are from the same tumor. So on the basis of this, it is difficult to differentiate between that. But yes, we can see from these two decisions, this can be a high probability that is because these were high uptake. Chances of malignancy was higher in the PET images.
Thank you, sir.
Age is something which should deter us from thinking primary malignancy first. If I have to think 30 years, I would keep benigns also like vasculitis probably would be first on my differentials finding.
If you are from nuclear medicine.
So yeah, we'll start the pathology discussion. So she's a 30-year-old female with complaints of cough for 3 minutes. There are multiple variable sized lung nodules and few mass-like lesions are present. The differentials which were considered were metastasis and GPA. So biopsy from left lung mass was done and we received tissue cores. This is histopathology. This is a low power, low magnification images. As you can see, there are multiple tissue cores which are present and they are completely blue, full of sheets of cells which you can see at this magnification. And so this is the intermediate power. You can appreciate that this is more or less monomorphic, and in between you can see some few large cells which are coming. And the cells are intermediate to large. You can see them many large cells which are scattered around, and they have moderate cytoplasm and amphiphilic, moderate amphiphilic cytoplasm. Some of the cells have indentations, some of them have conspicuous nucleoli. There is vague acinar formation at places, though not very clear. There is no definite gland formation as such. So it's like a solid sheets of cells which we are seeing here. And some few more images, you can see these are the blood vessels which are present. There is no significant necrosis or any angiocentric pattern which we can appreciate in this magnification, various representative images which we have seen. These are some few large cells and which are identified here. And occasional mitotic figures and quite some we could find some eosinophils also which are admixed with the tumor population. Not very significant, not pushing towards any particular diagnosis, just that few eosinophils were admixed. And this is just highlighting few eosinophils, and these are the large tumor cells. So these are fields of cells. One can appreciate the mitotic, atypical mitotic figure in this case. So this is some malignant tumor. So just few of the points that it lacks features of GPA, necrosis, vasculitis, or any other fungal profiles or superadenoid infections. Thus diffuse infiltration by intermediate to large cells with mild pleomorphism. Mitotic figures are appreciated. So with this morphology or pathology, one would always think of a lymphoma first, and other differentials before concluding lymphomas can mimic an undifferentiated carcinoma. Within the types of lymphoma like anaplastic large cell lymphoma, mediastinal large B cell lymphoma, although it's not a mediastinal mass per se, but sometimes it can infiltrate the lung also. So we have other germ cell tumors because patient is relatively young. So the three main DDs, there is lymphoma, undifferentiated carcinomas, and germ cell tumor were kept in our differential, and immunohistochemical panel was put. So we all know that cytokeratin, that is PAN-CK, is the broad panel to identify a carcinoma, and you can see that it's completely negative. So this tumor has eaten, which completely replaced the native lung parenchyma, and it's composed purely of these tumor cells. This is negative. CD3 is a marker for T lymphocyte, can highlight a few scattered cells which are present. By and large, the predominant population is negative. This is CD20, which is diffuse, intense positivity, and you can see that this is a low magnification image. Each and every single cell is positive for the CD20. So this is indeed a B cell lymphoma, which we will further categorize now. You can highlight, you can appreciate the large nature of these cells in this IHC. Though in the HNE didn't look that much, it's large, but here you can see it's quite large. So after that, this is CD10. So CD10 and BCL6 are markers of germinal center origin. So we'll see what those are. So these are the markers which are positive. We can take 30% as cutoff, which are positive for both. CD10 is a BCL6 is a nuclear marker. We have CD10 as a cytoplasmic marker. Both are positive. BCL2 is anti-apoptotic proliferation marker. You can see that it is diffusely positive, more than 70% of the population. After that, we have our K67 or K67. So this is more than 60 to 70% positive in the highest proliferating area. We need to see which has the highest value. So this is quite high. And MIC is the oncogene promoter, which is usually surrogate for MIC rearrangement status, which we do in all cases of DLBCS, which is negative. These are some, we have a cutoff of 40%, so which is negative here. Cyclin D1 for mantle cell lymphoma. These are the endothelial cells which are positive, but the tumor cells are negative. So this is not a mantle. MUM1 is also another marker which helps us to categorize the cell of origin. MUM1 is for non-GCP or post-germinal phenotype, which is also positive. However, the CD10 takes precedence in the algorithm which we are going to use to classify. So to summarize the markers, we have positivity for CD10, CD20, CD10, MUM1, BCL2, BCL6, and negative for CK. And some of the images which I haven't showed are MPO for myeloid sarcoma, because those eosinophils were there, and one could also think of when there is a diffuse tumor in a young patient, one would also think of myeloid sarcoma. CD130 to see if there is any plasmacytic differentiation or any other lymphomas which can present with CD138 positivity. Not much of a plasmablastic morphology per se, it has a centroplastic morphology. So MIC is also negative, secondary is negative. K67 or 60 to 70% in the highest proliferating area. So before we also did MIC rearrangement status by fluorescent in situ hybridization technique. This is a break apart probe which we use to identify these signals. You can see there is a pair of one green and one red, and one green and one red. All of them are fused, so it is not rearranged. This is a representative image that it is negative for this MIC rearrangement. Before we utter the diagnosis, just briefly see the morphological approach to pulmonary lymphomas. So by and large, the most common one include the extranodal marginal zone lymphoma. So unlike the pictures which you saw in the previous slides, you can see that these cells are quite small, and they infiltrate around the bronchus, and these are called as lymphoepithelial lesions. So more than 5 atypical lymphoid cells which is infiltrating the bronchial epithelium, they are called as LES, which are classic of marginal zone lymphoma. So they are heterogeneous, small lymphocytes and few monocytoid cells with plasma cells, and it can infiltrate the residual germinal centers and make a follicular appearance. And the cells are usually negative for CD10 and BCL6 because they are not of GCP origin, and Ka is less than 20%, which are completely against all our cases. So this is a cytokeratin marker. You can see the disruption of CK, bronchial lining epithelium, which is disrupted by these atypical lymphoid cells, and this is CD20. This is beautifully infiltrating the epithelium of the bronchial mucosa here. This is very classic of margin zone lymphoma, external margin zone lymphoma, which is not like this case. So another entity is a lymphomatite granulomatosis. This is a misnomer. This is not a granuloma. This is a angiocentric polymorphous infiltrate. It is a neoplastic entity. The etiology is EBV. It is driven by EBV. So EBV positive large B cells can be seen along with reactive T cells. It can present as multiple bilateral nodules, which can cause necrosis. And the grading of lymphomatite granulomatosis will be done by the number of EBV positive cells. So grade 1 to grade 3, depending on the increasing gradient. Necrosis is frequently present, which is unlike our case. Next one is intravascular large B cell lymphomas. These are quite rare, aggressive external non-Hodgkin lymphomas. Can identify these are the septae, which you can see, and atypical lymphoid cells are present within the capillaries of this, and you can see a big arterial sort of thing and contains these large cells. These large B cells are within the capillaries, and because of the vascular distribution, it has multiple systemic presentations. CNS, skin, lung. Lung is eventually, it is invariably involved in case of intravascular B cell lymphomas. This is due to the lack of integrins and ICAM1, which doesn't enable the cells to pass through the endothelium because there is lack of adhesion, and then it is just limited to the vascular area. And it causes poor prognosis because of the delay in the diagnosis, non-specific symptoms. Biopsy diagnosis also gets delayed. So it's one of the aggressive tumors. And coming to this case, so we have here the diffuse proliferation of large B cells with centroplastic morphology. It can also have immunoplastic and anaplastic morphology. And it is conventional, the morphology wise, you cannot distinguish a nodal DLBCL from a primary pulmonary DLBCL of that sort. Morphologically, it's not distinguishable. And sometimes the cells can be spindled also, which can lead to erroneous diagnosis also. One has to be aware that because of the pinching artifact or because of the nature of the lesion, cells can have a variable morphology. You can't always expect those large B cells. We do IHC algorithm. What we follow here is Hans algorithm because of we use CD10, BCL6 and MOM1. CD10 is positive, we call it as a GCB phenotype. CD10 is negative and MOM1 is positive, we call it as non-GCB phenotype. So, and always have to rule out other differences which are done in this case. So, and do a mixed BCL2 rearrangement status because of the poor prognosis it offers. Mixed rearrangement and BCL2 rearrangement makes it a double hit lymphoma. This is not a MIC was negative in this case. So, to thank sir, you were right on target. This is indeed a case of a diffuse large B cell lymphoma NOS. GCP phenotype, and it's negative for mixed rearrangement. This is the WHO classification, fifth edition of hematolymphoid tumors. We have the commonest one include the marked lymphoma of the lung, pulmonary DLBCL, lymphomatite granulomatosis, intravascular large B cell lymphomas, along with few histiocytic disorders like pulmonary LCH and pulmonary Erdheim-Chester disease. So we have covered most of the entities, but for our audience, we see that when do we call it as a primary pulmonary NHL? It occurs for less than for 0.4% of all lymphomas, and it is quite rare, less than 1% of all lung cancers. When there is clonal lymphoid proliferation involving the lung, parenchyma, or the bronchi, with no extrapulmonary disease at the initial diagnosis or for 3 months, it was mentioned by sir also. And the presentation can be asymptomatic or some non-specific symptoms like cough, chest pain, dyspnea, and it can arise in a background of immunosuppression or autoimmune disorders like rheumatoid arthritis, systemic lupus erythematosus, and Sjogren's syndrome. So this leads to immune proliferation related transformation to marked lymphomas, and the transformation also can go to a DLBCL. So few points include this marked lymphomas occupy for 70 to 80% of the cases of primary pulmonary lymphomas, followed by DLBCL and lymphomatite granulomatosis. So the issue with the diagnosis of marked lymphoma is it was also called a pseudo lymphoma. So even a reactive lymphoid proliferation, lymphoid pneumonias, lymphocytic interstitial pneumonias, which can create diagnostic confusion between these entities. So one needs to consider that. Other include the other benign or indolent B lymphomas like CLL, SLLs, and mantle cell lymphomas, which are also quite low on the cards. So the commonest one is small lymphomas, followed by DLBCLs, and this we have covered this, and plasmacytomas also quite low. Bucket lymphomas occurs in young age, and extremely rare. A few other rare lymphomas include anaplastic large cell lymphoma, which we initially saw in our DD. So this algorithmic approach by using proper IHCs will help us to achieve this diagnosis. Pulmonary DLBCs are the second most common primary pulmonary lymphomas, which occupy 5 to 20% of the cases. The mean age of diagnosis is 60 years, the age of 38 to 70 years, and half of the etiology is de novo, and half is because of transformed malt lymphomas. So it is usually present in the periphery as single or multiple well-defined nodules with necrosis or cavitations. It can occur in immunocompetent as well as in immunocompromised people, but if in immunocompromised patients, it is usually EBV driven and EBV positive. In this case, LMP1 was negative, and eventually this lymphoma spreads to the mediastinum and extrathoracic areas. The prognosis is poor. The median survival of 3 to 5 years. So apart from this fish studies for DLBCL, there is testing by NGS which has led to explosion of knowledge in this with regards to DLBCL. Many of the author groups have tried to classify based on some clustering techniques or by novel algorithmic methods. For this, they have performed whole exome sequencing and targeted sequencing to identify the what are the recurring mutations, copy number alterations, and structural variants which are present. In addition to NGS, there is also gene expression profiling. One of the group called British Columbia group identified dark zone signature, which is seen in germinal center bead type of DLBCL, which carries poor prognosis. So this is usually done more of an experimental way, not for routine patient care. So these are the few existing classifiers which are available. One is Schmitz et al. They are the one which are initially started. They have multiple subtypes based on the mutation. For example, MEDI88 followed by CD79A mutation, Notch1 mutation, EZH2 mutation. Wright et al. Multiple categories. Here it includes P53 also. And Chapoy et al. Because of 5 clusters, he has done this, and Lacey et al. By different groups. So they have done using multiple techniques to form this type of classifiers, and each might carry a different type of prognosis or any targeted therapy which can be available. So another thing is the outcome based on this, they classify them as with these set of types. For example, GCB origin, ST2 and EZB negative, dark zone negative signatures will have a better outcome compared to the poor outcome because of the ABC subtype and dark zone signature percent. So these multiple subtypes of DLBCs are helped to classify the prognosis. I could find a study based on a Polish lymphoma research group with regards to primary pulmonary NHLs. It was a very small study, but however, it composed of 78 patients where the median follow-up was for 33 months. Naturally, the indolent lymphomas of NHL had better prognosis, significantly better overall survival compared to the high-grade ones, 94 versus 68. So, but there was progression or relapse which was observed in 1/3 of the cases in both the groups, and progression-free survival did not vary between these two groups. This patient had 30 years. I was just thinking about whether any other cases have been reported like this in a younger age spectrum. There are one case report which I could find that this patient was a 21-year-old woman with primary pulmonary DLBC. So take home message from this is that it's an uncommon disease. Primary pulmonary lymphomas, especially DLBCs, can have clinical manifestations. Sample limitations and artifact can exist because endobronchial sometimes your FNAC may not conclude. And you can have multiple differential diagnoses. We have a systematic approach by morphology, immunohistochemistry, and your molecular whenever needed to help us achieve the diagnosis. So, thank you for your attention. So, thank you, sir. Please give a thumbs up applause. So, we like to.
So this case actually, highlighted multiple learning points, not just from the radiology and from a, presentation. One second. I'll just bring the radiology once, for those who, joined a little late to just. Sorry. Which is insurance? Yes, sorry. So this was the, radiology the patient comes with. A 30-year-old, comes to your clinic. Like an undergraduate teaching cannonball metastasis, these look like, multiple. And metastasis is what anyone would think. The patient is young, she was married very even a few months earlier, and a lot of things which go into the psychological aspect. And she underwent a biopsy, used a bronchoscopic approach elsewhere, which was reported as mild capillaritis. So it was, like granulomatosis with polyangiitis, like, GPA on the cards. And one course she could have taken was that biopsy taken as, suggestive and treated on the lines of vasculitis. But the learning point for this case was that when you're clinically you're thinking, and in multiple lungs nodules, when you don't have a primary which is clear, a histopathological conclusive diagnosis of a sample, I think, was most important. And then I think this also leads us to think that the best diagnostic modality for a lung mass sampling till today's date, if you talk of yield, is image guided percutaneous biopsy, which is performed by radiologists. We have multiple bronchoscopic modalities, but for large lesions the yield is good. But even they might not hit the lesion, and a percutaneous biopsy is required. Third thing also is the site. This is just my perspective. The patient is being told all the time, you have a metastatic cancer, you have a carcinoma, your survival is like this, and then you putting it forward that no, let's wait for the biopsy, let it come, and then I would say this is a diagnosis which has a better prognosis than a metastatic carcinoma would have risen, and I think was referred for image-guided biopsy to radiology, and I think it was we were not thinking lymphoma at all. It was the last of the last thing we were thinking. We were thinking more on the lines of a GPA was one thing, and a metastatic, cancer was the second thing. From radiology and other comments from the house.
Corroborate that the image guided biopsy does help us yield larger tissue core. We use 18 gauge to, at times 16 gauge also needles to achieve that size of the core which is required by pathologists to give a image guided biopsy in such large lesions.
So it was a difficult case, and I think our tremendous job to make the diagnosis. So Dr. Bala has also described how sometimes the small cell was looking the large cell, and large cell was looking the small cell. We are not able to make it with small function or large function, but yes, we have taken. So that's the case there.
So, what happened to this patient, sir? Chemo or any other? Any more comments in the discussion on this?
We have one more previous experience with a similar case, because that was the DLBC of last year. It was multiple cavitating nodules in 60 plus years. So the very unusual thing was that DLBC histology has been reported in that's it. So that is also.
We'll just do on EBER and see. I wanted to say that we'll do on EBER and see because if you have taken on, that is more sensitive. Inform Soumya sir. We do this.
Usually, we end about some, patterns of markers that we have prognostic significance. Can we do that? Or have you done that?
So, I think Dr. Soumya is a better person to answer this, and mostly now it is done for research purposes. For routine diagnosis or for prognosis, it's not done. It's routine. So, thank you for your attention. Thank you.